Hi, I'm Casey Knudson. I'm a child and adolescent psychiatrist. I work in primarily outpatient clinic, both in Nampa and Boise.
Okay, should I get started? We good?
I think we're
Okay.
good. Thank you.
All right, great. So thanks for joining us today. Casey and I are going to be talking about anxiety in autism spectrum disorder. Um, so go ahead and move to the next slide. Okay, so we're going to review the prevalence and type of DSM-5 anxiety disorders in those with autism spectrum disorder. Also going to review how to assess for anxiety and then treating anxiety. I will be going over the psychotherapy component of that, and then Casey's going to take over to talk about pharmacotherapy. Next slide. So many of you know what an anxiety disorder is. It's basically a fear of something about the world or environment that seems above and beyond what would be expected and impairs functioning. So we all experience anxiety. That's a very typical emotion to have. In many ways, it keeps us safe, protects us from harm. But there are times where that anxiety becomes irrational and kind of overtakes somebody's experiences and therefore makes it hard for them to go about daily life. There are several different types of anxiety disorders, which include separation anxiety, selective mutism, social phobia, social anxiety, panic, agoraphobia, generalized anxiety. Mainly, separation anxiety is fear of being separated from loved ones or that harm is going to befall a loved one. Usually, we see it in younger children. Selective mutism is there's a lot of different reasons for a child to have selective mutism, but sometimes it's kind of because they don't want to speak in novel or new situations and they're afraid of negative evaluation. Where specific phobias can run anywhere between, from having fear of weather, fearing the dark, fear of heights, to fear of health procedures, things like that. Social anxiety, so fear of negative evaluation by others. Panic, which is just having very intense physiological symptoms of anxiety, which then in turn can lead to agoraphobia due to fear of having panic outside the home. And then generalized anxiety, which is just chronic worry about a variety of different things. Sometimes with anxiety, we see a overlap with autism symptoms. So experiencing sensory overload is common if you have anxiety. And of course, individuals on the autism spectrum also have sensory issues. But the way that I differentiate between sensory issues related to autism versus sensory issues related to anxiety is there are far more different kinds of sensory behaviors we see in autism, including sensory seeking behaviors, as well as being overloaded by sounds that don't normally bother other people. So that's a kind of a good distinguishing kind of factor. Next slide. So there's a lot of different research articles about how common anxiety disorders are in those with autism spectrum disorder. And I would say, as I read the literature and review the literature, it seems like every study is different. Um, there is one study that indicates that the cumulative incidence of being diagnosed with an anxiety disorder for those with autism is about 50% by 30 years of age. A recent meta-analysis, though, that I looked at that looked at just community-based samples of youth with autism, which for a lot of our primary care providers, those are the kinds of kids that you're working with, indicates that approximately 30% will experience clinically elevated symptoms of anxiety, and about 20% will be diagnosed with an anxiety disorder. If you contrast that to community samples of, I guess, typically developing youth, roughly about 20% have anxiety symptoms at some point. So perhaps it's a little bit more elevated in those with autism. Next slide. So some in my practice, some of the common things that I notice in terms of anxiety symptoms include just fear of change and novelty. So the insistence on sameness that we might see in autism sometimes can lead to more intense reactions to change. unusual specific phobias. So I've heard of a lot of different kinds of things that individuals with autism are afraid of. Murals, for example, or somebody with a beard, or certain toilets. So kind of maybe things that you might not see in individuals without autism. Of course, other symptoms that can manifest as a result of anxiety is sleep disruption. So especially having a hard time getting to sleep, getting up in the middle of the night and having to crawl in with parents. Hyperactivity and restlessness, that's another common thing that I see, especially as I transition kids into my office. They might seem very hyperactive and need some time to settle down, but after some time, they do settle down. So it seems to me like it's more an anxiety reaction to being in a new situation. And of course, anxiety can manifest as learning difficulty, so not being able to pay attention in class and focus. So another thing is anxiety and autism is often associated with increased behaviors like aggression, such as self-harm behaviors, repetitive behaviors, so more intense need to do repetitive behaviors for self-regulation, and then avoiding social situations can be another indicator of heightened anxiety. Next slide. So the anxiety prevalence in autism could certainly be higher due to a variety of things as it relates to autism uniquely. So issues with emotion and sensory regulation, understanding social intent, because social experiences can be very confusing or frustrating. And of course, that can lead to developing just social anxiety. Also, differences in the ability to communicate distress or frustration, therefore, things manifesting as anxiety rather than being able to communicate when somebody is feeling overwhelmed. All of these things can lead to just the environment being more threatening. And of course, there's been some literature to look at some of the strongest indicators of anxiety or things that are most strongly associated with anxiety in youth with autism. And one of them is peer relationship problems. And of course, the subsequent social isolation that comes with that. Next slide. So in looking among the research studies, the prevalence of anxiety disorders, if you look at the proportion of the types of anxiety disorders that those with ASD experience versus the proportion of these of anxiety disorders in the general population, there isn't much of a difference. So specific phobia accounts for about 41%, social anxiety about 28%, generalized anxiety about 27%, panic about 6%, separation anxiety 14%, and agoraphobia about 5%. But separate from that are the compulsive disorders like obsessive compulsive disorder. OCD used to be classified under the anxiety disorders, but it was pulled out into its own category. I think with the recent, 10 years ago plus of the DSM-5. So there's a group of compulsive disorders, including like hoarding disorder, trichotillomania, obsessive compulsive disorder, excoriation disorder. And obsessive compulsive disorder does seem to be more prevalent in those with autism compared to the general population. And a lot of anxiety disorder symptoms will not fully manifest until a child is older. If you remember my previous presentation that talked about differential diagnosis, a lot of anxiety differential diagnoses we're not really considering until school age or beyond. Next slide. So there aren't currently in the public domain or any good published highly utilized instruments for assessing autism specifically, assessing anxiety specifically in those with autism. There is, I think, an adult version, an anxiety instrument for adults that is being used, but there really isn't anything specific to ASD. Why could that be a problem? Some of the items on anxiety measures are specific to what you'd expect a typically developing child to maybe think about, where maybe individuals with autism, it might not be as relevant, such as I'm afraid of other people evaluating me negatively. This might not be a thought that an individual with autism thinks about or really resonates with them, although that's not always the case. So for now, a lot of people are using things like the Scared. Of course, the Scared is in the public domain. It's for kids 8 to 18. The nice thing is there's also a parent report version. Why would that be important? Because a child with autism could potentially underreport their symptoms for a variety of reasons, whether that be communication differences, cognitive differences in terms of understanding the items, or something called alexithymia. I believe that's how you pronounce it, where there's kind of a reduced insight regarding their own internal emotional states. So having this collateral information can be helpful. Next slide. So some of the things I ask about when I'm thinking about when I'm thinking that a child might possibly have anxiety, I ask about if the child has any intense or persistent fears, any fears that impair their ability to go about day-to-day life or impair their family's ability to function, because often families do inadvertently accommodate the anxiety symptoms. How long has the behavior been happening? When did the behaviors occur? Just to understand the function. And then, of course, evaluating for other potential co-occurring mental health issues related to mood, irritability, given its high co-occurrence with anxiety. Next slide. There's been longstanding evidence that psychotherapeutic and pharmacological interventions are the most effective for treating anxiety in combination compared to just either intervention alone. And so referring to mental health counseling and or med management if anxiety is significant is important. Next slide. Of course, encourage continuation of other therapies since they may have a downstream impact on anxiety symptoms. For example, speech language therapy to work on communication, OT for sensory modulation, and of course, encourage family to access broader services for themselves just to help support them and to encourage a stable home life. Next slide. So psychotherapy. Next slide. So cognitive behavior therapy has been shown to be pretty effective treatment for children and adolescents with anxiety. Cognitive behavior therapy has a strong behavioral component, which really tends to resonate with those on the spectrum. So behavioral components include graduated exposure with subjective units of distress ratings, putting together a fear hierarchy, and calming strategies. And then, of course, a cognitive component, which is just evaluating the reason for the fear, maybe doing some cognitive restructuring or thought balancing, psychoeducation, problem solving. These in combination can be really helpful for managing anxiety, and there's very, very strong empirical evidence for that. Next slide. It is more appropriate for school-age kids who are verbal because of the cognitive restructuring piece. But nonetheless, starting treatment early is very key because some anxiety disorders in older individuals with autism become more resistant to CBT. So the sooner they can get into therapy and the sooner they can into therapy when it's appropriate will be important. Nonetheless, you could still use behavior-based strategies for managing anxiety for those individuals who aren't as verbal, such as the graduated exposure and the calming strategies. Next slide. Okay, so now Casey, take it away.
Thank you, Dr. Harlan. So I can't agree more with what was already discussed about the importance of psychotherapy in the treatment of kids with anxiety disorders. It certainly stands to reason that, particularly in our youngest or most vulnerable children, that attempts at therapy would be beneficial before we consider pharmacologic intervention. But of course, my role today is to talk a little bit about pharmacotherapy and the use of pharmacotherapies in our children with autism who have anxiety disorders. And it's important to note the effects or the impact of medications and that they are rarely used as the primary treatment for anxiety, as I already mentioned. Next slide, please. So when we're looking at pharmacotherapy specifically for anxiety disorders in children under the age of 6, next slide. It's important to remember that to first talk about when we're going to treat with medications. And so we're usually looking at treatment with pharmacologics if they've had a negative response, a poor response, or even a partial response to psychosocial treatment. And the timing of that is really important as well, of at least 12 weeks or 3 months. So we want to ensure that they've given a really good try of some other sort of psychosocial intervention. And we want to be sure that symptoms are severe enough to the point that they're causing some level of decompensation. So that could be weight loss. It could be that they're missing school on a regular basis. It could be that they're complaining of somatic symptoms or physical illness. And in instances where there might be a strong family history, I always, when I talk to families about treatment, particularly our younger aged youth, is that there has to be two criteria that are met. Number one, that they're experiencing distress, and number two, that it is causing some level of functional impairment. What that means is that they're impaired in their function in at least one area of their lives, whether that be school, whether that be their home life, whether that be peer interactions, and as kids get older and maybe into adolescence, if that's impacting employment or their place of work. Next slide. So what are we going to do first? Recommendations are specific to using Prozac or fluoxetine first with concurrent psychotherapy. Whenever we're prescribing Prozac or fluoxetine in the treatment of young children, we're going to want to be sure that we review that black box warning for suicidality. It's recommended to do an 8 to 10 week trial starting at very low doses, somewhere between the 1 to 2 milligrams per day dose. Maximum dosing in these children, remember, this is kids under the age of 6, is going to be somewhere between 5 to 10 milligrams per day. There is increased risk of what we call activation syndrome or behavioral activation in this group in particular. How that manifests in little kids is oftentimes challenges with sleep. They can have some increased motor activity, maybe even mimicking tick-like behaviors, and increased talkativeness. So we'll call this like a mini mania, right? So it's like that excessive energy, restlessness, irritability that can manifest itself. And usually the way to combat that is to lower the dose of the medication or to discontinue it altogether. Recommendations in kids of this age is to stop or discontinue medication use after a period of approximately 6 to 9 months of effective treatment. When we're talking about effective treatment, we're talking about remission of symptoms. Remission of symptoms means that symptoms are gone. So that can take some time to build up to that dose that's going to remit symptoms, and then that period where symptoms are well controlled, and then we work on a gradual down titration and off of medication. Next slide. If Prozac doesn't work, Zoloft is typically considered the second option. And again, with concurrent psychotherapy, the same black box warnings apply to sertraline as they do to fluoxetine. So it's important to keep that in mind. We'll start at 5 milligrams generally, and maximum dosing of that medication is somewhere between 50 to 75 milligrams per day. I was actually just talking to a colleague of mine earlier today who has a 5-year-old on sertraline currently, has titrated up to a dose of 50 milligrams with really positive response. So that's very consistent with what we're seeing as a normal therapeutic range for this kiddo and approaching that maximum dose. The same plan for discontinuation is recommended here. Other medications that you could potentially consider is fluvoxamine or escitalopram, though the data with these specific agents is very, very limited. It's limited even with fluoxetine and sertraline, which are the two that I just mentioned, but even more so with anything outside of those two agents. Next slide. Medications for things that are not recommended for children under the age of 6. Medications without concurrent psychotherapy. Use of TCAs. There are way too many risks associated with these medications that it would not be recommended to use them. And ongoing use of benzodiazepines, which means any use outside of a very short course for severe anxiety that surrounds a medical procedure, a dental procedure, or some specific solitary instance like flying on an airplane for a vacation. Next slide. Now, when we're looking at pharmacotherapy for anxiety disorders in children over the age of 6, and this is a much broader range, so ages 6 to up to 17, or to our adolescent age range. Next slide. So when do we consider treating with medications? Again, when anxiety is considered to be moderate to severe. Like Dr. Harlan mentioned, this is really difficult to get to that like specific assessment of, oh, here's a metric. If they're at 18 or above, they qualify through some questionnaire. They're very limited in the use of kids with autism, and so it can be really difficult to make that determination. And so you're really going to gauge it based on patient response and parent response in those instances. And again, we want there to be an inadequate response to CBT. Next slide. So first line treatment again is going to be with the use of fluoxetine or sertraline. In this instance, either one works. So you can really make a decision. And a lot of times it is a judgment call. I would argue that if we're trying to treat some concurrent depression, fluoxetine would be the better option to go with first. If we're really primarily focused on anxiety and that is the glaring issue, I would opt to go with sertraline first in those instances. This can be used as monotherapy or in combination with CBT. Most of the literature supports a combination of both. Um, we want to make sure that we're always reviewing those same risks, that black box warning. And I know I reiterate that a lot here, but it's because talking about those points is really super important with families. If the first trial of either fluoxetine or sertraline is ineffective, then it would be recommended to switch to the alternative agent or the one that we didn't first use. So, for example, if we started a patient on fluoxetine and they didn't respond well, we would then switch them to sertraline or vice versa. Next slide. Some second line treatment options would be duloxetine, which is an SNRI or a selective serotonin and norepinephrine reuptake inhibitor. With when we're using this class of medications, it is a bit more important for us to be monitoring things such as height and weight, blood pressure and pulse, because they do have a tendency to potentially cause some hypertension. An interesting fact about duloxetine is that it's technically actually the only medication that is FDA approved for the treatment of generalized anxiety disorder in children. All other medications are technically off-label uses. Other medications that we sometimes use are escitalopram, more traditionally in our adolescent population. So that's children ages 12 to 17, and fluvoxamine. Next slide. Third line treatments that we could consider is citalopram, which is another SSRI, or venlafaxine, which is another SNRI. Other considerations is buspirone. One word of wisdom or pearl about buspirone is that we really have to use higher doses of this medication in order for it to be effective. I find that far too often people are using very, very low doses of this medication and then giving up because they're not getting response. Particularly in our adolescents, it's recommended to get to a total daily dose of somewhere between 40 and 60 milligrams total daily dose in order for it to be effective for treatment. Outside of that, those parameters are oftentimes going to undertreat. The other consideration with buspirone is that it is not a PRN medication. You cannot give it as needed. It will not work if you do it that way. It has to be scheduled. So don't prescribe it as needed. It must be a scheduled agent in order to be effective. Other uses can be guanfacine and clonidine. Those we sometimes use off-label for treatment of anxiety, and clomipramine, more traditionally used in the treatment of OCD. Next slide. What is not recommended is paroxetine, which is another SSRI, as either a first or second line treatment. The primary reason for this is because there's increased adverse effects through many studies. So this isn't just a solitary study. This is multiple studies that have been done in children and adolescents, causing things such as insomnia, that activation syndrome, as I mentioned, also diminished appetite and vomiting. They can also experience a lot more discontinuation symptoms. So because of its half-life, missing a dose of paroxetine can actually be quite impactful on children and may cause them to not want to take it. When we say discontinuation symptoms, we're talking about flu-like symptoms, body aches, headaches, chills, sometimes even to the point of fevering, though that's pretty rare, and suicidal ideation. And as we can all note, benzodiazepines as first-line therapy is not recommended for long-term treatment. So once the lowest therapeutic dose is reached, we can titrate the SSRI or the SNRI after about 1 month if it's tolerated. So usually because of that window of somewhere between 4 to 6 weeks in order to achieve full response, we need to be careful not to titrate any quicker than that unless in an acute setting. If we're switching medications, generally the recommendation is that we cross titrate and not wash out. The exception to that rule is with MAOIs. If we are using those medications, which are very old school and very uncommonly used in kids, we just are going to want to cross titrate versus doing a complete washout in an effort to avoid development of worsening symptoms or recurrence of symptoms. The literature will tell you recommend or discontinuation can be considered after 12 months with a gradual taper, and of course monitoring for relapse. If for some reason symptoms recur, recommendation is to restart them back on pharmacologic intervention and then consider tapering off of medications if they get to a period of remission for somewhere between 2 and 3 years. If they again relapse after coming off of medications, then it is likely that they're going to require ongoing treatment. Next slide. Here is a quick reference dosing guide that I've provided in the next couple of slides just for your reference and hopefully for your utilization moving forward. I've included in here the commonly used psychotropic medications for children and their starting doses as well as their identified maximum doses. I reference these charts frequently when I'm dosing my kiddos, and it is okay to do so. I would certainly recommend doing that than just guessing off the top of your head trying to remember what the most common dose is. So these are just this slide, and then you can go to the next slide, Lindsay, are just for our, again, school-aged youth and then our adolescents. The children under the age of 6, really, it is fluoxetine and sertraline, so I didn't make a chart for it. It is those two agents. I would be really hesitant to use anything outside of those two. Am I frozen? I'm frozen on my screen, sorry.
We can hear you, but
Yeah,
yes,
my camera randomly froze, so in a very interesting position. So,
there.
are there any more
Let's,
slides?
yeah, where to the references? I'll just,
Perfect. So there are some references there, but for your review, and I appreciate the opportunity to speak with you today.
great. Thank you so much. Casey, sorry you froze. If you
That's
want to try
okay.
and put your camera on again, go for it. Um, so Elena and Casey, we're going to open up for questions right now. Let's start out. We have a question from Serena Poland. What do you think about hydroxyzine as a PRN anxiety med? Several of my young teen clients have been prescribed this med.
I lost audio and just got back, so was somebody asking me a question?
Oh, yes. So we do have a question in the chat. What do you think about hydroxyzine as a PRN anxiety med? Several of my young teen clients have been prescribed this med.
That's a great question. We do use hydroxyzine fairly regularly as an as-needed agent. The data or literature in support of it is pretty limited, and that's why I try or tend to avoid it when giving talks about evidence-based treatment. But hydroxyzine is used regularly, and I use it in my clinic as well for an as-needed medication. It is certainly recommended over um, benzodiazepines.
Great.
Gabapentin is also something that I have seen used. And I would say that it is a highly effective treatment in anxiety specific to trauma. So, in particular, with our kids who have hospital-based trauma or medically induced trauma, they respond really well to gabapentin. So, I've used it a lot in my kids on a burn unit. I've used it a lot in my kids who have just repeated medical procedures and medical exposure. And it tends to be effective. And that's not to say that you couldn't extrapolate and use that in alternative settings as well. But again, the evidence base for it is pretty limited.
Great. Thank you. We have a lot of questions coming in, so let's keep them coming. Oops, I lost that one. If a student has Buspar prescribed PRN, do you recommend contacting parents about the guidance that it should not be PRN?
Yes. And I know that's difficult. It depends on what your role is on the team, and I completely understand those limitations. But Buspar used as a PRN medication is just simply not going to work. It's not, that's not how it's designed. That's not its mechanism of action. And so I unfortunately fear that when kids take it, and you see it all the time, when kids take it, PRN, it's not going to work. And then they say, oh, this doesn't work. We failed that agent. And it's like, no, you really didn't.
Okay, thanks, Casey. From Richard, what do you do if parents want metabolism testing to verify if a particular drug will work?
It depends. I think if parents are insistent, I will pursue it. So, like gene site testing is probably what we're referring to. I think the evidence is really pretty mixed on it. I Unfortunately, I fear that most families, when they look at that data, are looking at things incorrectly, if I'm being honest. So I think they are looking at what's in the green category, what's in the yellow category, and what's in the red. And while that's helpful, really it's important to understand how their body is metabolizing medications. And so I think looking at that specific metabolism is what's important. And so I would encourage anybody who's pursuing gene site testing to really be informed about what that testing shows and to educate families accordingly. Meaning, just because a medication is in the red doesn't mean a kid can't take it. It simply means that their body metabolizes it differently, and we need to be mindful of that.
Casey, we do have more questions, but I was
Yep,
remembering
I've
you have
I've
a
got
hard
to
stop.
jump off and see
Yes.
a patient, so I will please forward me all those questions, and I will answer all of them.
Oh, Casey, thank you.
Yep,
For those, we will get back to Casey on those questions. I really appreciate it. Thanks for your time,
my
Casey.
my pleasure.
We do have Elena and the rest of our team here. Elena, we have a whole lot of medication questions.
I know there's one about, what do you do if a family tried psychotherapy and they don't like it and they want to do just medication. So I've had lots of parents bring that up with me. Not every psychotherapist is the best match. And so some of it is trying to find the right match for the child. So rapport is half of the contributing factors to success with psychotherapy. And, I really ideally, I like to have a psychotherapist that obviously is familiar with autism and kind of the unique kind of psychotherapeutic needs for an individual on the autism spectrum, and also who does have some really good understanding of CBT. There are just some approaches that aren't going to be very helpful. And so, really, somebody who can take a behavior-based approach, know how to tailor it for that individual child is going to be important. So that's all I have to say. I know those sometimes are hard to find. There may be some folks on here who are phenomenal at that, and that's wonderful. But yeah, just keep asking specific questions around their experience with autism, their experience with CBT. There's other counselors, I think. I know Travis, you might want to chime in with regard to that.
I'm on my phone. I apologize.
No problem.
Trying to get into the mute thing. It's different than the computer screen. Um, I think Dr. Harlan, you kind of hit the nail on the head, though. I don't know if there's really anything additional that you can provide within um, that explanation and that psychotherapy piece. I mean, outside of looking with inside your, providing folks here that people around me that I know are supportive and have that experience, but that doesn't really help across the state and other locations and things like that. So I think it's just finding those individuals and really kind of assessing and really advocating for parents to interview them um, as what they know and what they can do.
And medication can only go so far. And CBT or approaches for how to evaluate your anxiety, how to respond to your anxiety, how to evaluate the situations that prompt your anxiety, those are really important key lifelong tools. You may not need to go to psychotherapy for very long to be able to learn those tools, but they're going to be really key to getting through any aspects of life that cause anxiety. They're also going to be really key to building an individual's confidence in what to do. And in the fact, I have tools to manage my anxiety so that in a situation where I normally would avoid it, I have the tools to not avoid it. And I know I've done this in the past where I've gone out and experienced a situation that I normally would avoid. So these tools are going to help build an individual's confidence to manage their anxiety. So, and medication is helpful. Sometimes medication can be wonderful in terms of even getting somebody to go to therapy or to even
Mhm.
try these interventions. But really, it's going to be doing the work. And you kind of have to do some work if you have some really entrenched habits.
I'll,
So,
can I add a thought to that, Dr.
sure.
Harlan? Uh, the I always kind of initiate that the medications and therapy as they go together, and with an anxiety, uh, it can help kind of take the edge off, so the therapy is more effective for them. ERP, so exposure response prevention, as well as DBT, dialectical behavioral therapy, all have one as a treatment. They're very effective treatments and modalities, but in addition to that, there are some uh, informed processes for neurodevelopmental or neurodiverse populations with inside those modalities that are very effective, that I found very effective within my patient populations and working with kiddos. The generalization of the skill and the parents' want of like, hey, I want them to be able to go to school. We may have to pull back and sometimes provide expectations that that will be our goal, but our first mode is to be able to get out of the room, right? Like making little tiny steps and then start adding to that, because anxiety has uh, more than likely become the the motivator behind their behaviors. And so we have to first gain success, as what Dr. Harlan was pointing to, and that confidence that we can get through some of these smaller steps and goals, and then we start to add to the larger ones. And I can't see anything other than
Travis, can I
myself,
ask you a quick
Dr.
question?
Harlan. Yeah, go ahead.
You mentioned interviewing the therapist. Do you have any specific questions that, we could have patients, parents, ask their therapist to know that, like, what modality of therapy they're receiving, or, how can they ask their therapist those questions?
So parents need to ask, does the provider have any specific education with neurodiverse populations? So like, have you done any or continuing education credits towards this population? One, first and foremost, do you have any certificates that indicate that you've done such? So outside of kind of that concrete education, I so like I have families that have siblings that are going to other therapists and things like that, and collaborating and corroborating with the family in the other therapist, having the family talk to that other therapist in the context of, does the has the therapist done this before with another child, right? Like, have they had other neurodevelopmental families, children before? And if so, like, how many? Is it a percentage of their caseload? And if it's low, and it, if the relationship is tight with the kiddo, I would be hard pressed to tell the parents to go somewhere else where they might find a therapist that maybe have more experience. But if they're interviewing them, it's typically due to that the relationship is not quite making it there, and to find out other therapists that might be able to be better skilled at creating those relationships with the child and the family, based on that they've had previous experience with that. So really just an educational review and an experience questioning.
And from what I learned, CBT is hard work, right? For the child and the parents as well. So the parents should be involved. And oftentimes I have parents say, I don't know what's going on in therapy, right? Like, or I don't get much feedback. And so then I question whether or not it actually is CBT that is going on. But, at what level should the parent be involved?
Yeah, the CBT in particular, ERP, which is kind of based off of a CBT platform, DBT for sure. Exposure response prevention, dialectical behavioral therapy, and those acronyms uh, will have homework. They'll have things to go home with to do. There should be at least a once a month check-in with parents. Sometimes care plans, treatment plans, you'll identify that this will take 6 weeks with the child alone, and then bring parents in at the later down the road to then educate them on what we've been doing, to then bring that into the home and start to generalize these things. The first, if we're not getting anything outside of the session, then we're not probably likely to get too far. As as a neurodiverse population is going to struggle with generalizing, with taking something here and moving it over to this side, right? Like, I think all providers probably on the call and parents on the call are going to look at like, oh yeah, there's lots of times where I say, hey, like, look, go jump in the bathtub, and we're literally trying to jump into the bathtub kind of a thing. So that literal piece, that rigidity, we have to look at and identify like, hey, how do we take this and help them gain the skill of just building themselves outside of this one narrow idea. And that's going to take parents involved. Typically, I would say at least every session having a 5-10 minute check-in, or within my program, I have a communication program that I can communicate back and forth with parents that's secure. We have care plans that are bringing them in at once a month, or within that care plan, bring them to provide that psychoeducation and that generalization. If that's not happening, I would begin that interview process as to what our expertise is within the area.
I have something to add too.
Yeah.
Just from like a rehab therapist perspective, a lot of these kids with autism they have language deficits, they have sensory needs, things that are roadblocks to them engaging in some of these things, right? So I have found success like starting speech and language therapy, starting OT, managing some of that stuff, and then getting them engaged in these other things. I just have found that's a better route with some of these little kids. And the parents then see them make success, and then the parents are more bought into working on these other things because they're like, okay, they're communicating more, or managing some of these sensory issues and that rigidity and their inability to engage in some of that stuff. So that's just a route that I think you can take too with these things. And I tell parents all the time, humans are like shoes. Sometimes the first pair of shoes you put on is not the best fit. And you try a different pair of shoes, you try a different therapist, you try a different doctor sometimes, right? You try something that fits better. And sometimes parents just need permission to change who they're working with. And good therapists know when they're not a good fit for a kid, and they refer them to someone else. So
yeah.
Great. Tom, I see your hand. Let's hear from you, and then we're actually going to transition to our case that Elena has brought for today.
Yeah, I think that case for referral to OT is often really overlooked because they can work with self-regulation, and through that improved self-regulation, as Jamie mentioned, like other things improve as well. And so I often use an OT evaluation with these youngest kids and have seen really great success, and then can add in other things. So often I start with OT to get that self-regulation piece down. And then, as always, I'll chime in about, parents' self-regulation allows them to co-regulate better. So thank you.
Travis, yes, let's go to you, and then Elena, you've got the floor.
Yeah, I apologize, Lindsay. I know we're trying to get to Harlan. I'm real quick, within that age population, as Jamie pointed out, and Tom, the anxiety is with the parents with those little kids. So working with the parents in particular, sending the parents to their own psychotherapist. If the anxiety breeds anxiety. So if we've got anxiety that we're seeing in the kiddo, there's potential that we have an environment that's breeding that anxiety. And it's really, really important to look at having those parents get into their own work and treatment. And as Tom points out, like, if we're not getting those parents help and support, our kiddos aren't likely to get where we're wanting them to be. Okay, sorry. That's all. I won't talk anymore.
I think a lot of these comments just are a testament to the fact that everything's very multimodal in terms of addressing the needs of individuals on the autism spectrum. And so there's no one easy answer, but and CBT isn't always the best answer either, but it's the best tool that we have for addressing anxiety in those on the spectrum. So yeah, you just kind of have to encourage parents to not overwhelm themselves and go with what's working. Jamie, I really like your comment about making sure they're getting other interventions for other things, because of course that could have a downstream effect on their anxiety symptomatology. So that's a really great point. So anyway, I'm going to go ahead and get started with the case. We're trying to figure out a way to fill the time. Sounds like we probably could have filled the time with it, continuing to have this discussion, but I think this case is actually really relevant to what Casey and I just discussed, and so I thought it'd be nice to revisit it. We want to get that started. This is a case presentation that Amy and I did together back in January of 2023. We were presenting on it to talk about how to approach a multidisciplinary team evaluation. It was about a child who we had recently evaluated as part of a team framework. But the reason why I think this is helpful for this particular session is because the child came in with co-occurring anxiety symptomatology and possible obsessive compulsive disorder. And so it kind of dovetails nicely from what we've been talking about today. So one of the reasons why having a multidisciplinary team evaluation is important, and one of the reasons why not every child that our cohort sees is appropriate for evaluation in, say, a primary care setting, is because sometimes kids present in a very complex way. And so multidisciplinary team evaluations are really important for children who have difficult differential diagnoses to identify. There's maybe a question about cognitive level and how that might be impacting their presentation. There's maybe subtle or complex symptoms, meaning there are symptoms that kind of overlap with other diagnoses. And then potentially there's other coexisting diagnoses. And then they may have a complex medical presentation or a complex psychosocial history that continues to cloud the picture as well. So typically in a multidisciplinary team evaluation, we look at cognitive functioning, adaptive functioning, social, emotional, behavioral functioning, communication, a comprehensive medical examination, sensory and motor functioning, and family functioning. So we look at a whole host of different domains. Next slide. And of course, I'm just going to briefly review kind of the framework of our clinic, but I know there are other clinics out there too. Other folks from different agencies are on here who also do multidisciplinary clinics. But just really quickly, it's just usually the child is referred through developmental pediatrics, usually from another provider in the clinic who feels that the child has a pretty complex presentation. Usually, then when that happens, we do have speech and OT do their evaluations on separate days. Then myself and Dr. Francis do our evaluation. Usually that includes physical exam, the ADOS. I do the ADIR. And then we team huddle afterwards and then do feedback with the family, typically same day. Next slide. So the case I'm presenting on is a 7-year-old female. She came in with symptoms of inattention, difficulties with social interaction, and anxiety and compulsive behaviors. She had been previously diagnosed with ADHD combined presentation, a language delay, and an anxiety disorder. my thought there is if a child has issues with language and pragmatic communication and ADHD as a diagnosis, those are huge reasons to refer on for an autism evaluation. Next slide. So birth history, pretty unremarkable, full term. At the time of evaluation, the patient was taking amphetamine, dexamphetamine. This is more Amy's part of the evaluation of the presentation. EpiPen, there was no sleep concerns, but the child was a picky eater, but was growing well. Family history of ADHD, learning differences, bipolar disorder, anxiety, and depression. And at the time, the child was residing with parent and parent's boyfriend, and the parents were divorced. Next slide. Developmental history. So walked within the later stage of average at 16 months, spoke single words and phrases at typical times, but parent was noticing issues with comprehension and performing ADLs without prompting. And then also there were some social difficulties. So really struggling with how to engage with peers, although wanting to engage with them. And then having kind of these preoccupations around monsters and germs. So the therapies included mental health counseling for these preoccupations and anxiety, to address attention issues, and then speech language therapy to work on articulation, but they had been discharged by the time we saw them. School services included being in the second grade in the gen ed classroom, had a 504 plan with a shared aide. Next slide. So per the information we gathered via the ADIR, which is kind of similar to the parent interview that our cohort does, the ADOS, which of course is a different instrument than the STAT, but kind of served the same function in this case. And then the SRS, which is what a lot of our cohort is familiar with. We found that the child met several symptoms in the social communication domain, including difficulties with reciprocal social interaction, more limited nonverbal communication, difficulties engaging with peers, sometimes just saying statements that aren't appropriate to the context, and more limited imaginative and pretend play. And then in terms of repetitive restrictive behaviors, some more kind of repetitive speech, asking repetitive questions, having a strong interest in certain movie scenes and wanting to view those repeatedly, was really particular about certain daily routines and also insisted that others adhere to those routines. And then sensory issues related to sound, touch, so even kind of things that wouldn't normally bother others, or was kind of more attracted to things that other people, might not be attracted to. So a lens cleaning cloth. I remember she was very, very focused on that. Having an aversion to sticky substances, and also liking to watch things move like ribbons. And of course, these symptoms had been present at a young age. Next slide. So also as part of the evaluation, so this child ended up having to come to me for a separate evaluation soon after the multidisciplinary team evaluation was done because of some insurance snafu. And so I couldn't do a lot of my testing, and I had to get some insurance authorization. So I was able to do more interviewing related to the OCD symptoms that we had noted in the multidisciplinary evaluation. So some of the obsessions that mom had reported included fear of contamination and germs like illness, disease, vomiting, sticky substances, fear of getting others ill, and then compulsions that were used to neutralize the anxiety related to the obsession. So hand washing to the point of cracked skin, requesting that her mom take her temperature all the time, constant questioning and checking in about whether she would vomit. And then some other kind of compulsive behaviors that she did included rewriting and checking spelling in her written work, and not allowing her parent to take things from her room because she did not want to part with those things. Next slide. So in terms of cognitive functioning, she had average intellectual functioning on IQ assessment. She did have noticeable difficulties with pragmatic communication and getting her thoughts out. So, for example, she did some memory testing and she had a really hard time with the recall, kind of the free recall component of verbal information. But when she was cued and provide structure, she was able to easily recall that information. So it wasn't necessarily a memory issue per se, but more an issue with getting her words out. And then difficulties with sensory modulation, fine motor skills, as well as sustained attention and processing speed. And so I think ultimately, with all this information, the team had diagnosed autism spectrum level 1, ADHD, and OCD. Next slide. So there were a lot of recommendations, but really in a nutshell, we recommended that she be considered for an IEP at school under autism spectrum disorder for pragmatic language, social skills, intervention, and OCD-like symptoms. So working with, say, a school counselor on kind of addressing those OCD symptoms in the school. Community-based interventions such as ABA or BI as it relates to building social skills, communication, SLT to work on pragmatic language, OT for fine motor, emotion regulation, and mental health counseling for OCD, like we had talked about earlier in this session. And then, of course, continued med management for her ADHD symptoms. Next slide. So just some key takeaways. So really, when it comes to, there was a couple of things that made this complicated. One is that there was a bunch of differential diagnoses to consider. The other is there's like this OCD overlay where there's kind of like these routines and rituals that might seem more related to autism than OCD per se. And the way I usually differentiate those two things is if the rigid adherence to routines and rituals is kind of due to an insistence on sameness and not necessarily rooted in an obsession and a need to do things a certain way as a serving, which would be serving the function to decrease the anxiety related to the obsession. And so in her case, she really needed to have like do certain rituals, like wash her hands over and over again as a way to reduce her obsession related to illness and germs. And so that's a little bit different than just say, I like to do things this way because it's always been done this way, and I have a hard time doing it in a different way. So those two types of things are different from one another. The other thing is the fact that she's female, and typically it's just harder to identify autism in females for a variety of reasons. Part of it is because our cognitive schema about what autism is typically is related to what we typically see in boys. And we know that in girls, the restricted interests, the social motivation may look different. And even so, we think about base rates, like what is the chances if I refer this child for an evaluation who happens to be female, that they'll get diagnosed with autism, because we know that there's a ratio of roughly 3-to-1, boys being diagnosed versus girls being diagnosed. And especially when it comes to milder symptoms, it's even a larger difference in that ratio. So anyway, just kind of some things to think about when it comes to thinking about when to refer in your own practice and when to evaluate. Next slide. Other things to kind of think about is that children with mild ASD often have multiple co-occurring diagnoses coming into the evaluation and may still have a lot of those diagnoses leaving the evaluation. And some things to think about for referring for additional assessment include, the child is experiencing significant social struggles, like problems making friends, even in talking with them, maybe not really understanding your point of view or others' points of view. Maybe they're struggling with pragmatic communication. So, some things that I usually note when I first talk with a child is, does the child not directly answer my questions? Do they kind of not give me context when I'm trying to have them answer my questions, like, so it's hard for me to follow what they're trying to say, and then they struggle with conversation repair, or just generally struggle with reciprocal conversation with me, and just seems more one-sided, either whether it be I'm doing a lot of the talking or they're doing a lot of the talking. The other thing to think about is, okay, child's been put on ADHD meds, child's been put on anxiety medication and has had psychotherapy for anxiety, and we're still seeing that they are struggling in a lot of areas. So that might be another reason to refer on. And of course, so that there's buy-in and follow through, it's important that parents also share this concern. Next slide. And I guess that must be it. So that's it. Any questions?
Elena, I wanted to back up a little bit. We did have a question from Preston that Travis is going to address. The question was, is there a specific age when therapists would say the items discussed with the child or the teen in therapy are confidential? Travis, can you talk about some of that confidentiality piece?
Yeah, there's been a transition in Idaho with confidentiality with our adolescents and our children. As of right now, the current law, that parents have full access to all PHI, a child under the age of 18, and there's no protected information for a child under the age of 18. And psychotherapy, being a team member of the family, I discussed through that process with them on how to help create some privacy within the child's treatment, with limits to that being, suicidality and some of these crises that we would bring folks into. So that's kind of like a general confidentiality piece. Speaking directly to like when to discuss treatment plans or treatment care with patient and parents both involved, is really dependent upon the parents' values and their direction of care for their kiddo, and whether they want to have these diagnoses known at the time for the child or not. I'm an advocate to begin as early as possible, similar to trauma or to grief, within using developmental appropriate language and examples, but always following a parent's and a family's values first, before diving into anything specific from that. I hope does that answer your question, Preston?
Yeah, that helps. Yeah, we were just kind of curious about that. So that's very helpful. Thank you.
Mm-hmm, for sure.
Thanks, Travis. Okay, sorry, Elena, we had a little deviation there. And our question, we did have a question about your case, Elena. Was developmental trauma considered due to divorce and the living situation changes?
And I went ahead and answered that while Travis was talking. That was not something. So certainly, of course, having a divorce can be a very difficult and stressful experience for a child. In this particular situation, there was a lot of support from both sides of the family. There was a lot of stability in the home. That wasn't a significant psychosocial stressor that we felt was contributing to this child's presentation. But that said, had there been themes of anxiety related to separation, themes related to having to go back and forth between homes, which she did not. She actually did not have contact with father. So there had been a pretty stable home situation. But I can understand how that would be a key piece.
I just wanted to highlight one more thing. On the slides, we touched a little bit on how um, high functioning autism plus ADHD can look like severe ADHD. So oftentimes we see kids with severe ADHD who are refractory to medications, perhaps that are being tried in the medical home or with a primary care provider. And so I think if you have some of these kids who aren't really responding to medication and aren't really doing well at school, it's really important to kind of think about autism, right, as an underlying diagnosis because it often co-occurs. So I just wanted to highlight that as well in this population.
Yeah, and I would especially want to make, think about one of the ways that helps that I help myself try to disentangle those things. Because I actually recently had a child come see me where they had a multidisciplinary team evaluation with our group, and we didn't determine that they had autism at the time of the evaluation, but they're coming to me almost 7 years later. And what's been helpful for me in terms of interacting with that child is their pragmatic communication, and their conversation skills and whether they have friends. Those are really, really key indicators. This child has really significant ADHD, but there's other things going on that made me think, well, maybe this is a one that we missed 7 years ago. So there was something about pathological demand avoidance. Has that been addressed? With Preston, did you have that question or wait, who was
No,
that?
I don't. Take it away, Elena. There was.
Oh, okay. Can't remember. Sorry, Preston, if I put you on the spot.
Oh,
If it wasn't you.
No,
Katie.
it was
Oh, it's
no. I
Katie.
saw that question. Someone just mentioned
Okay.
that it's been coming up more recently. That people have brought it up. I've heard of that occasionally, but it wasn't me.
Okay, it wasn't you. Okay. Um, so I do believe that that's a construct that is more popular overseas, like in the UK. It's not necessarily a construct that's part of any sort of diagnostic manual. I think it's a phenomenon, and I think, have addressed it at some point in time, I guess, over the course of these sessions. Um, Pathological demand avoidance, of course, is just not doing anything that people ask you to do. And that can be a real big challenge for learning and for skill building and those kinds of things. And for some reason, it seems to be a phenomenon that happens a lot in individuals with autism. My sense is to take it on a case by case basis and try to understand the function of the behavior. So for some kids, really just understanding like would do with any other situation, it has to be individualized to the child, and calling it pathological demand avoidance, really all it does is describe what the behavior is. I don't think it really helps to do anything other than say it doesn't really help to understand the function or reason behind it. So that's how I would approach it. There may be some changes to that as we move forward, but right now I don't think it's something that we tend to diagnose in isolation or as its own construct.
Thank you. Great discussion. We were kind of all over the board, lots of questions and answers and discussion today. So thank you so much, everybody. So let's wrap this up. We are going to reconvene in 2025. We will come back together January 9th from 12:30 to 1:45. Our topic is understanding and managing ADHD in autistic children, presented by our panelist, Travis Hodley. So thanks so much, Travis, for kicking us off in January. Again, one more plug for that January 16th session about genetics. Make sure if you want to join us that you go in and register for that class or that session. Okay, thank you to all of you. Be well, and we will see you in 2025. Take care, thanks.